Hello and welcome. I'm Cassidy Ovula with the Center for Optimizing Rural Health, and I will be your moderator today. We have an excellent webinar. Our topic is addressing revenue cycle management challenges in rural hospitals. And as we go through the webinar, if you have questions, please feel free to type them into the chat box, and we will anonymously ask them during the Q&A portion when our speaker is finished. If you would prefer to ask your question out loud, just send us a message in the chat and I will unmute your line during the Q&A time. We will not be unmuting all of the lines at once though. So I would like to go ahead and get started by presenting our speaker, Sylvia Alcala. Sylvia is an AHIMA approved ICD-10 trainer, as well as an AAPC approved instructor with over 30 years of experience as a leader in health information management. Ms. Alcala is an adjunct coding instructor in the Health Information Management Program at Texas State University in San Marcos, Texas. She sits on advisory boards for the Health Information Management Program at St. Philip's College and is currently a director of HIM and the privacy officer for Connolly Memorial Medical Center. In her previous employment, she was the coding compliance director for a 650-bed hospital. Ms. Alcala has served as president of the Alamo Health Information Association, as well as participating in AHIMA coding roundtables and serving on the AHIMA committee for accrediting coding exam questions. Welcome, Sylvia. Thank you for being with us today and sharing your vast knowledge, and I will turn the floor over to you at this time. Sylvia, can you hear us?
Can y'all hear me?
Yes, we hear you.
Oh, good. The only thing is oh, there it goes. Okay, here we go. All right, thank you. Okay, I'm going to get started. Revenue integrity. Now more than ever, getting revenue cycle done right is critical to our health and our organization in turn of our ability to successfully carry out our mission to our patients. And I'm not sure how many of y'all are coders or directors on the call or even CFOs. You all know how challenging, revenue cycle is and coding and billing and everything that goes on with it. The revenue cycle in a hospital or health system is a continuum, and each department and role within the cycle has to work in unison to be successful. Due to the nature of today's healthcare environment, some staff may not even realize that they are a part of the revenue cycle. If there's a weak link, the entire system can quickly be in trouble due to issues with compliance, reimbursement, and ultimately patient care. Who is revenue cycle? And this is really a refresher on some of these parts. Maybe some of y'all know some of this stuff, some of y'all don't. But of course, as soon as the patient walks in the door, that is revenue cycle. We start with registration and scheduling. And if you notice, that's a big part. If they put in the insurance number right, they copy the card, it's in the system. Everybody's heard garbage in, garbage out. If everything is correct in there, the billing section will be able to bill it out correctly once it's coded and goes through all the circle in front of you. Of course, if they're coming in for a surgery or something, you're going to have to notify the insurance. If they're going to do an MRI, you need an authorization number, and then you have utilization. Case manager has to call in report or fax, clinicals to an insurance company. And then, of course, you need an authorization number, and make sure that you always have that authorization number in the medical record, or we scan our authorization numbers or whatever they fax to us in our electronic medical record to make sure that we have it in case if we need it for an appeal. And then, of course, you have coding. And once all goes through all those sections, coding gets a record. They review if you all have a CDI on the floor or a concurrent coder. They go up to the floor and code it. Then it comes down to the coder. The coder codes it. Then it goes to charging and billing. Of course, at our hospital, I'm not sure how everybody else does it, but we do a lot of the charging. We charge for OBS. We charge for infusions and injections. We charge for ED levels. Then it goes to billing. And then, of course, adjudication. What, does it need anything else? Do we have to send more clinicals? Is there something we missed? And then collections, which is your last part of the wheel. And I'm going to go a little bit into more of all these 8 essential functions that you really need, and they have to be in place for the end. Even one of these departments that I gave, or examples that I gave, one break in this chain stops payment and may subject the organization to the loss of revenue for services expended. Like a link in the continuous chain, to have integrity for reimbursement, all links must be intact. If you forget to get the authorization number, they're not going to pay you because you forgot to get the authorization number. If you got the authorization number on the wrong CPT or wrong surgery, they're not going to pay you. If the case manager didn't fax clinicals within a certain amount of time, that's another reason for them not to reimburse you. So you have to make sure you're following all these areas. Of course, the fundamental concepts, your eligibility, your patient financial advocacy, the coverage analysis, your ABN. Do you get the patient to sign an ABN for your Medicare patients? The MOON, that you have to have our patients sign for your observation notice, and then your charge master. Your charge master has to be up to date. You know that the codes are, for the outpatient coding, the CPTs are updated in January. For the ICD-10, they're updated every October. So you have to make sure your charge master is up to date, that what you're coding is going out correctly. Because a lot of these insurance companies are updated as soon as they come out, some of them don't. Your patient access, which is your admitting department, functions associated with eligibility and patient access need to be progressed to complete patient financial advocacy, including coverage analysis prior to service delivery. Eligibility detail requires up-to-date out-of-pocket liabilities and maximums. Benefit details are links to benefit per policy and access to specific coverage policies. I'm not sure about you all, but at our hospital, we have a goal. We have to collect point of service 100,000 every month. That is our goal. And then for the coding and billing, they give us a goal. What our charges were last month, they give us a certain percentage, and that's what we have to collect. So we have goals that we have to meet. Your patient financial advocacy, when providing financial counseling and upfront financial estimates, patients assume the order schedule service meets coverage criteria of their plan. Obtaining prior authorization does not equate to ensuring coverage. Of course, sometimes patient comes in and the physician admits him as an outpatient and it's an inpatient procedure only. So you have to be very careful with that. Or you do an inpatient, you admit him as an inpatient and it's an outpatient procedure only. So you have to make sure that everybody knows which are your inpatient procedures only, which are your outpatient procedures only, because this is another way that you're going to be able to, not get the income that you're supposed to get for your hospital. And I know I'm talking a lot about financial and revenue, but the bottom line is if we don't bring in the money that is due to us, the hospital can't function. We can't pay salaries. We can't, do quality care for our patients of supplies that we need. So we have to make sure that we bring that in. And I put this link there for the COPs and the CFPs. The CMS develops conditions of participations and conditions of coverage that providers must meet to participate in the Medicare and Medicaid programs. And I just put that link so in case if y'all want to go in and look what it says in there. CMS also defines conditions for payments. So all that information is there. I go in a lot to gov.com and get information on coding or anything updates. The working phase of the meeting, who's the champion in the department? Who owns the process? Describe essential processes. Who's doing what in each department? What information is used to manage this process? And how is the process documented? And what is a monitoring tool used for monitoring this? And really, I put down here who's the champion. You should have more than one. And who owns the process? Everybody has to be responsible for what they're supposed to do. And if somebody's out, another person should should drive that. So it's really, really important that we have this in place. The key elements in common terms: Medicare contractor means Part A and Part B Medicare. Overpayment means any funds that a person has received or retained under Medicare to which the person, after applicable reconciliation, is not entitled. Person means a provider or supplier furnishing services under Medicare. Person does not include beneficiaries. So, just make sure who are you treating? Are you returning money that's not yours? Meeting deadlines. A person who has received an overpayment must report and return it by the later of the following, the date which is 60 days after the date on which the overpayment was identified. So if you get an overpayment, you have to return it within 60 days. If not, you're going to get penalized. And of course, everybody has gotten Humana letters or Medicare letters. They tell you that if they don't get the payment back or if they don't hear from you, they're just going to take it out of where they put the money in for you. So, they'll take it regardless. The 2 midnight rule: short inpatient hospital stays when the physician expects the beneficiary to require less than 2 midnights of hospital care are again payable on a case-by-case basis. These are really, really important because the RAC is really targeting this, and insurances. If you have, 2 days or less than 2 days, they're asking why shouldn't this have been an observation? They'll deny it. If you have enough indicators and everything to appeal it. If not, they're correct. Why did the patient leave? I mean, you should have put him in as an observation to begin with. Your midnight inpatient cases, CMS was clear that 1 midnight inpatient stays are neither rare nor unusual. Commercial payers have targeted this for years. So if you have a 1 midnight inpatient, like here at our hospital, if they come in really sick and we admit them as an inpatient, and they need to be transferred out to another facility because we don't have the resources to take care of this patient. Of course, it is an inpatient and they do meet the criteria, but you have to be really, really careful if you admit an inpatient and you discharge them on the same day. Medicare focuses on quality and value over time. Initiatives paying for reporting data. Example, your inpatient quality reporting, outpatient quality reporting with payment reductions if the data is not reported, the data is not reported. Current initiatives paying based on data, hospital-acquired conditions, hospital readmissions. We know that if you're readmitted within 30 days with the same diagnosis, they combine these accounts. If the hospital acquired condition, if the hospital acquired it, this is also taken out. And of course, your inpatient reporting and outpatient reporting, if you don't report this, you'll take a hit on your DRGs or your inpatient payment. Your hospital acquired condition reduction program, Medicare, like many other payers, doesn't pay for hacks, but another step has been taken so the hospitals are incentivized to reduce their incidence of hacks. So, they'll penalize you if you have a lot of hacks. If you do, of course, if it's a CC or a major CC for coders, they're going to take it off. So you really won't have that DRG payment. Hospital readmission reduction program, provisions to reduce the MSDRG payments for discharges for excess readmissions of certain applicable conditions. And here are some conditions that they really look at, like your acute MI, your heart failure, your pneumonia, elective, your total hip and knee arthroplasty, and your COPD. 3% is the maximum a hospital could lose if deemed to have excess readmission. So it's, 3% is a lot. Some people think, oh, it's just 3%. If you bring in a lot of revenue, it's a lot of money for that. Things to monitor given the cost-cutting incentives, your care, your delivery of care, your outcome, your patient satisfaction, your financial impact, what else? I mean, there's a lot of things going on in the revenue cycle. Of course, I didn't put your case mix index, your patient satisfaction, your core measures, audits. There's a lot of things going on through all the revenue cycle. And registration, and I repeat this again, who's the champion, who owns the process, describe your essential processes. Every department should have this. I just put registration here, but every department should have, who is that and who is their backup. And always make sure you cross-train or 2 or 3 people know the same job function. You don't want only one person to know that job function, and then they're gone or they're sick and you're stuck. Your MOON, your Medicare Outpatient Observation Notice of their observation, treatment, and implication of care eligibility requires notice to observation patients in the form specified by CMS effective August 6th, and to notify your beneficiaries receiving observation services for more than 24 hours. And documentation is key to providing proof that the hospital has met its obligation to deliver. We have our admitting department go up to the floor and make sure the patient signs this or knows this. Also, our case managers help with this to make sure, and we also scan this form into the medical record to make sure that if anybody would come and audit us, this form would be in our electronic health record. Your Medicare Outpatient Observation Notice applies to hospitals and critical access hospitals. Added requirements to provide observation notice to the Medicare Participation Agreement. And then you have your annual updates. Your annual updates to the Chargemaster are linked to your CPT and HCPCS coding updates. If you don't have it, consider a subscription to the HCPCS or the coding clinic from your AHA to stay current. It's really, really important that you stay current with your codes, your Chargemaster. Your Chargemaster is the link. If your Chargemaster is incorrect, everything you're submitting out is going to be incorrect. And I just put, they didn't have 2019, so I put 2018, your RAC audit. And we are Region B. I know they changed the regions, but we are B. These are the regions for different states, like New York, Florida, and California fall in Region D. This is how much money the RACs have recouped back from coding audits, or coding that was done incorrectly or was undocumented correctly. And if you notice, look at Region A, 9.2 million, Region B, 6 million, Region C, your 43 million, and Texas falls in that. And then your Region D, 67 million. And the RAC auditors get a percentage of what they collect back. So they are making a lot of money, and that's what they wanted to do. They do audits. We get RAC audits all the time. Since we're a small hospital, we don't get that many pulled because you're only allowed to pull so many records and go back only 3 years. But it's really, really important, coding, case management, because if not, they're going to recoup the money back from you. And if there's one thing your CFO hates, is for you to collect money and then that you have to give it back. So make sure that it goes out correctly the first time. Your common problematic conditions, these are problems or diagnoses that auditors pull and the RACs pull. And this is statistically proven: your respiratory failure, your respiratory distress, your malnutrition, your sepsis, your encephalopathy, and your complication of care. These are high-paying DRGs, especially if you have them as a major CC or even if you have them as a principal diagnosis. So it's really, really important that if you use these diagnoses, you have the clinical indicators, to back it up. Because if you're denied, then you can go and fight the record and, put the clinical indicators down there. I make sure that we try and have 3 clinical indicators if we use these diagnoses. It's really, really important. And the FBI has gone to close the hospital in Florida because of sepsis. They were coding everything sepsis. So it's really, really important that you're careful with these diagnoses, and really with any diagnosis. If you're coding something, just make sure that it's documented and you have the clinical indicators to back it up. And here's an example. This happened at our hospital. It's respiratory failure. Jane Doe had a long history of cigar dependence despite the use of home oxygen, 3 liters of nasal cannula, and it's a she, not a he. She is admitted with shortness of breath. Documentation indicates COPD exacerbation with acute respiratory failure. The ED record describes a compensated acidosis as demonstrated by initial ABGs, and your respiratory rate of 28 with no accessory muscle use and no distress noted. 3 liters of nasal cannula applied. So, of course, this patient came in through ER and was admitted as an inpatient. So what are our diagnosis? And the coder coded acute respiratory failure as our principal diagnosis and secondary acute exacerbation of COPD, which was a CC, and then dependence on supplemental oxygen, and then dependence on nicotine. And our DRG was 189, pulmonary edema and respiratory failure. They pulled this record, an auditor did, one of the racks, and the clinical indicators for respiratory failure are shortness of breath, tachypnea, decreased rate or depth of respiration, wheezing, cyanosis, grunting with expiration. What is the patient's baseline? And then here's more of your clinical indicators. You have to check your arterial blood gases, your oxygen, and then the treatment plan, treatment of the underlying condition. Were they on a mechanical vent? Clinical validation of the acute respiratory failure is needed. The description by the ED provider does not support acute respiratory failure. No change in oxygen from baseline. Compensated acidosis describes a chronic respiratory failure. This is what the auditor replied. So if you notice, the left-hand side is our code, acute respiratory failure is a principal diagnosis, acute COPD, and everything that I read out. The auditor came in the rack that it should have been COPD exacerbated, query to rule out acute respiratory failure, which we didn't do, and query to assign the code J96.12, chronic respiratory failure with hypercapnia. And then, of course, your MSDRG was 190. The other one was 189. So, we took a hit on this, and now, we put in place where respiratory failure for sure we query, or we make sure that we have plenty of clinical indicators to back this up. It's really hard as a coder sometimes because you're trying to meet productivity and have accuracy, and they want you to put the records out, and sometimes you're rushing, and sometimes you can't do 3 or 4 records in an hour. And here's a comparison of the revenue. If you notice your MSDRG 189, the respiratory failure, my reimbursement was $7,241. My MSDRG 191, COPD with CC, was $5,503 reimbursement, and you can see the relative weight. And of course, the difference was $1,738 that we had to return. So, because they were correct. We didn't have enough clinical indicators to back up the acute respiratory failure. The audit process, regardless of payers, the audit process does not differ based on the payer, whether the audit is for coding, medical necessity, DRG validation, or quality. There are several steps utilized that do not change. It's really, really important. It really all falls into the same revenue cycle. If we get denials for medical necessity that we appeal, we try to appeal everything. If we think that, hey, we did it correctly, we appeal it. There is nothing that we don't appeal unless I see that there is no clinical indicators for the validation, then I do not appeal it, but otherwise we appeal it. Documentation, make it easy to understand. Documentation of the concerns should be straightforward and easy to read. And I make sure that I go up to the floors. I have a coder that goes up to the floors also. If the physician writes congestive heart failure, I make sure that we talk to him and we tell him if he could specify if it's acute, chronic, acute on chronic, systolic, diastolic. If he doesn't know, then it's just congestive heart failure. But otherwise, we try to make our codes as specific as possible. And this is an example of a true court case. Ryan, who was working at Texas State Medical Center, said the child was unconscious and unresponsive in the emergency room. Ryan said he mistakenly clicked a wrong button on the electronic charge that made it appear the girl was alert at one point. Charting mistakes are done sometimes, he explained. The point was important because jurors heard another prosecution witness read the medical record that indicate the girl was alert and oriented after arriving at the hospital. Evidence that the girl was okay at the hospital would undermine prosecution claims that Texas State Hospital ran the girl until she collapsed. We were sued because they said that the girl was okay when she walked in, and really the girl had already expired by the time that she walked in. But the nurse didn't document this correctly, so this medical center had to pay out of their pocket, to settle the case. So it's really, really important that if you're coding, even you make sure the code's there. And of course, we all know that if something's in a radiology report and it's not in the medical record, if it's an inpatient, you cannot code off of it. So we query the providers to, document if they can write it in the progress notes, or we make the queries as part of our medical records. But I know that a lot of the auditors like for the documentation to be in the medical records, in the progress notes, or in the dictation. Also, for sepsis, it's, there's providers that put sepsis for everything. So we make sure that we have the clinical indicators for that, for the sepsis. And then your adjudication, how health insurance companies process claims. Your private insurance have a variety of plans with many different rules. Each claim has to be examined very closely. Software edits have been developed that perform all these tasks to accept medical review. We have a program that when we code, if something's not right, if we missed a modifier, or if we broke a coding rule, it goes into this program, and then it goes to a coder, and the coder reviews it. And the coder goes in to check the record. If it's in there, we fix it before we bill it out to make sure that our claims go out clean. And also our billing department, double checks that the insurance numbers are correct or the insurance name is correct in there to make sure that everything is in there before, it goes out. The remittance advice explains to the physicians with a copy to the patient how the payment was determined. So everybody that has insurance gets this. And we don't separate our records like this is Medicare, this is, TRICARE, or this is, another insurance that a company has different. We code them all the same. We treat them all the same. We do everything the same for all of them because everybody knows that everybody, like Blue Cross and Humana, usually they go with what Medicare has. So it's really, really important that I know hospitals, because I've worked in a lot of different hospitals, that if it's Medicare, we're going to do it this way. No, you have to make sure that all your patients are done the same, just like you do Medicare, because as strict as they are, the other insurances are, just following their way, whatever they put into place, the other insurance company follow. The Office of Inspector General, the OIG, recently issued a semi-annual report to Congress. Its report highlighted include expected recoveries of nearly $3.35 billion, 925 criminal actions against individuals or entities engaged in crimes against the HHS program, and 682 civil actions, including false claims. And this is really going on. I mean, they expect to recover $3.3 billion from hospitals and physician offices and anybody that sees patients, your urgent care centers. And they have filed criminal suits. There's, believe it even now in this day and time, we still have a lot of false claims going out. People submitting bills that shouldn't have been submitted, or coding things that aren't documented in the medical record. Your Deputy Attorney General memo titled Individual Accountability for Corporate Wrongdoing. What does it mean for healthcare providers? Highlights the need to hold individuals criminally or civilly responsible for corporate wrongdoing. So it's really, really important. I mean, if you're asked to do something that's not right, question it. Today's audit environment, if you are treating patients and submitting claims, you will likely be audited. Appeal cases that are inappropriately denied. We get denials that maybe the diagnosis doesn't go with the x-ray, or the diagnosis doesn't go with what was being done. We go in the record and review it again, and was everything coded, and we appeal it. We try to appeal whatever we can. And we have 16 physicians that are also our employees like us. They work for the hospital. And if they're using, a code a lot that's, not paying us, we educate them and tell them, this is wrong, you need to be more specific, and they are. I mean, sometimes you can't use anything else, like your screening for osteoporosis, the Z code, it's denied a lot, and sometimes that's all there is. I mean, the patient does not have osteoporosis, so we have to use our Z code, and it's denied for our hospital. So it just depends what you're coding or what you're using. What not to do: do not wait until a few days before the auditor arrives to take action. Do not simply accept the audit findings such as accurate. Do not cease to file appeals. Do not begin self-denying or overusing observation in an attempt to avoid a future audit. If you really believe a patient should be inpatient, put them inpatient. If you think you can back it up, if they deny it, you appeal at the end. And always, if you can, appeal. You don't want them to think, hey, this hospital doesn't appeal anything. They just take what we're giving them. They start giving you more and more. So make sure that when they request records, usually the release of information lets me know, and I pull them and I see what they're looking at. Is there potential that they're going to deny us? You can be proactive. The expression, "we are only as strong as our weakest link," proves to be a true statement. This is very, very true. I mean, it starts with admitting, if they don't have the authorization numbers that they needed, our case manager, if they didn't fax clinicals and they want them to fax clinicals 3 days later and they didn't do it, I mean, it's that's a weak link, and you have to correct that. I mean, it's really, really important, because we need to bring in the revenue for our hospital or our physicians. And guys, I know how challenging revenue cycle is, with having case mix, patient satisfaction, the RACs, the queries, your core measures, cash goals, denials, your 2 midnight rule, you're getting physicians to dictate operative reports. I have problems with that we can't code without them. Coding your productivity and case managers, the physician sometimes doesn't want to discharge the patient. So, I know everybody has these challenges, just like our hospital does. Thank you very much. And if y'all have any questions, I'm ready.
Great, thank you, Sylvia. We actually do have some questions already in queue. So our first question, and if you guys have questions, please do feel free to go ahead and type them into the chat box, and we will definitely address them to Sylvia. So our first question is, we are a critical access hospital. Does the inpatient reductions for HAC, case mix, and readmissions, does this affect our patients?
I'm sorry, could you repeat that? I know that they're at critical access. Does what affect their?
So it looks like the question is inpatient reductions for HAC, case mix, and readmissions. They're curious if that affects their patients.
Yes, it does.
Okay. And the second question in the queue, who gets the burden of readmission when the readmission is at another hospital? For example, a patient is admitted as inpatient at one hospital, gets discharged to home, readmitted at a different hospital with hospital-acquired pneumonia.
With hospital-acquired pneumonia. So they were admitted at another hospital, you're saying, and then they're admitted to this hospital with hospital-acquired pneumonia?
Correct. So it looks
okay.
Correct. So it looks like they're admitted at one hospital, discharged to their home, and then readmitted to a different hospital with hospital-acquired pneumonia.
Okay, you would get, it does impact you, but if insurance companies are, when they're calling clinical, they have to make sure that that's in their clinical notes, that they had hospital-acquired pneumonia already and that they were discharged from another hospital. I would make sure, that's what our case manager does, make sure that they know that they're coming in from another hospital and they had, they're coming in with hospital-acquired pneumonia.
Great, thank
because
you.
it will impact them, definitely.
Okay, and the third question in the queue, can you recommend a good resource for physician, nursing, and coders to refer to for clinical indicators or education or webinar suggestions?
I don't have the book with me, but I have a book. It's in one of the other offices that I buy for my coders, and it's got the code, and next to the code on the bottom, it's got all the labs you can have for that and all the symptoms for that. And I can send you or email you, and you can email it to the group. I can put a copy of it and everything for you.
Okay, great. If you share that with me, I would be happy to share that with everyone on the website today.
And it's really, really good because, like respiratory failure, what I was saying about it, now we go to that book and we look through respiratory failure and we see what we need to have, because we try and use 3 clinical indicators for that. So we make sure that we have those 3 in there. Definitely. I will share that with you.
Great. And Sylvia, are there any other educational websites or webinars that you often look to that you might share with the listeners?
Well, I usually, they send me a lot of information for webinars and everything. And like right now, I'm looking for one that, is offering observation hours, and because observations are real challenging for the hours, the infusions, the injections. But usually I look through the HIC Pro, that company. They have a lot of different webinars, and AHIMA does also. AHIMA has a lot of, different webinars that you can take, and they record them, and then you can listen to them later also, which are really good. And I can send you those 2 with the email address so you can give it to the group.
Great, that would be wonderful. And it looks like that may be the last question we have in the queue. Oh, no, I'm sorry. I think we got one more. Is there a specific communication that facilities receive that state the facility is getting reductions due to readmissions?
Yes, but I think it's your CFO that gets that. The HIM director or the coders do not get that. It's usually administration that gets it.
Okay. Thank you.
They're the ones that get that, I know, because that's really important. It will really hurt an organization if you get a reduction on that.
Absolutely. Okay, I think that was the last question in queue, but we still have time. So if anyone would like to ask a question, just shoot us a message and we will unmute you, or feel free to type your question either privately to me, Cassidy Avila, into the chat box, or you can type it in to everyone, and we will be happy to read that on your behalf.
And Kathy, if they want to email me also personally, I'll be more than happy to answer their questions.
Great.
You can share my email address also.
Okay, well, we would be happy to do that.
Okay. I know coding, case management, whatever department you're in. I know if you're in one of these revenue cycle departments, it's really, really challenging. It's challenging to collect, especially in your emergency room, because the patients know that they can come in without, they don't have to give you anything. It's really, really hard for us to collect. That's where we get our, mostly where we can't collect anything, but sometimes when you're really sick, you're not thinking about money or payment. You just want to be seen.
Sure.
So we have to think like that also.
Okay, I don't have any other questions in the queue. We did get a private note that just says all the references you can include are the greatest help, and we will be happy to include anything that Sylvia has referenced in the webinar today, as well as the resources that she's mentioned during the Q&A. So we'll gather that all together and get that out to you guys. Sylvia is really helpful and willing to help. She understands the challenges, so we can definitely pass that along. And a lot of you have sent us your email address requesting the slides, okay. And we will definitely get you the slides. We send an email out. We try to get it out within 24 hours. Sometimes it's 48 hours after the webinar that includes a link to the recording back on our website, We always share these recorded webinars that we do monthly on the CORE website. We also put them on our YouTube channel, so they're accessible a couple of different ways to you. It just takes us a little bit of time to get those up, but we will send an email out with that so you can share this recording with anyone else. There's also a short survey. It's about 60 seconds. It just lets us know what you would like to see more of or any other topics that you would like us to present webinars for. That email will not have the slides attached. The slides will come directly to the email address that you sent us during the webinar today, so you can look for that in your inbox. Okay, so this is your last chance for any questions for Sylvia on the call. Otherwise, we'll go ahead and give you part of your day back. Sylvia, thank you so much. That was really informative and really beneficial, I know, to the hospitals on the call. So we thank you, and we'll give you part of your day back. Thank you for joining the call.
Okay. Thank you. And I will email you the book, and I will email you those two places where you look for webinars. Okay?
That sounds fantastic.
All righty. Thank you.
Thank you for
Bye-bye.
Bye-bye.
Bye.